Welcome to the Deep Dive. We take complex technical source material and really drill down, helping you achieve that professional level mastery.
That's the goal.
And today we're tackling, well, probably the most common medications out there. The NSAIDs, nonsteroidal anti-inflammatory drugs, and their cousins, the antipyretic-analgesics.
Yeah, these are absolutely fundamental. Pain, fever, they're the go-to drugs. But just because many are over-the-counter doesn't mean they're simple.
Not at all.
There's a real danger in underestimating their molecular complexity. So our mission today is to get beyond just the pill bottle. We want to help you master the pharmacology.
Understand those subtle, sometimes high-stakes trade-offs. Benefit versus toxicity.
Exactly. We'll dissect the core mechanism, that's COX inhibition, and then trace out all the consequences, the good, the bad.
The clinical benefits, but also those potentially severe toxicities.
Right. And then we'll compare the key players. Aspirin, ibuprofen, those controversial oxicams, paracetamol. Understand why a clinician chooses one over another. The professional rationale.
Okay, moving from just knowing what they do to really understanding why they carry specific risks for specific people. True mastery.
That's the deep dive.
All right, let's start with a bit of history. Context is key, right? Where did these even come from? Got to start with nature.
Willow bark. Salix alba.
People knew for centuries it worked for fever and pain.
Yeah, traditional medicine had it figured out even without knowing the molecules. That bark contains precursors to salicylic acid.
And the chemists eventually caught up.
They did. The sources point to 1875. That's when sodium salicylate was introduced specifically for fever and pain, isolating the active principle.
And then the big one, the prototype, aspirin, acetylsalicylic acid.
Introduced 1899, became a global phenomenon almost overnight.
But the concept of NSAIDs came later.
Right. The next major step was phenylbutazone in 1949. This was interesting because its anti-inflammatory effect was actually comparable to corticosteroids.
Wow.
So they needed a way to distinguish it. That's when the term nonsteroidal anti-inflammatory drugs, NSAIDs, was coined. It was about mimicking steroid benefits, but, without all the harsh side effects of actual glucocorticoids.
A non-steroidal approach, got it. And then things picked up speed.
Definitely. Indomethacin came along in '63, very potent but tricky to use. Then ibuprofen in 1969.
Ah, ibuprofen. That feels more modern.
It was a big deal, a propionic acid derivative. Its arrival really kicked off a whole wave of new, structurally different NSAIDs, generally better tolerated than the earlier ones.
So what defines this whole class? What are the shared traits?
Well, they all have analgesic, antipyretic, and anti-inflammatory actions. But, and this is critical, the strength of each action varies a lot between drugs.
Not all created equal in that respect?
Not at all. And importantly, they're not opioids. No CNS depression, no physical dependence, no abuse potential. Totally different mechanisms.
So they're not working on the brain's perception of pain in the same way?
Not primarily, no. They're especially good against inflammatory pain. They act mostly on peripheral pain mechanisms, stopping the pain signal from getting amplified locally.
But there's a central part, too.
Yes, there is. They also work in the central nervous system, in the spinal cord and brain, to actually raise the pain threshold. So it's peripheral and central. Gatekeepers, not just local numbing agents.
And chemically, they have something in common.
They do. Despite looking quite different, all the active NSAIDs are either weak organic acids themselves,
Okay.
or their active metabolites become organic acids in the body. This seems minor, but as we'll see with stomach issues, this acidic nature is actually a key factor in some major side effects.
Interesting. All right, let's dive into that core mechanism then. This is where it gets really fascinating. The big breakthrough moment. 1971, Sir John Vane.
Absolutely. Vane and his team made the crucial discovery. Aspirin and other NSAIDs work by blocking the body's production of prostaglandins, PGs.
That was the key insight, blocking PGs.
That was the watershed moment, yeah. Prostaglandins, along with related compounds like prostacyclin, PGA2, and thromboxane A2, TXA2, are all made from arachidonic acid.
Okay.
And the enzyme that does this conversion is cyclooxygenase, COX. So NSAIDs inhibit COX, and that shuts down the production line for these key signaling molecules involved in injury response.
Simple enough conceptually, but then it got more complex, right? It wasn't just one COX enzyme.
Exactly. That's the next critical layer. There are two main forms, or isoforms, COX1 and COX2. Understanding the difference here is absolutely essential for grasping NSAID risks.
Okay, break it down for us. COX1.
Think of COX1 as the constitutive one. It's the body's full-time maintenance enzyme, always active, performing vital housekeeping functions.
Like what?
Things like protecting the stomach lining, making sure blood flows properly through the kidneys, enabling platelets to aggregate correctly via thromboxane A2. You need COX-1 working properly day to day.
The essential worker, okay.
Okay.
And COX-2.
COX-2 is the inducible one. Think of it like the emergency response team. It's normally present in really tiny amounts.
Only called in when needed.
Pretty much. It gets rapidly ramped up, induced by inflammatory signals like cytokines, right at the site of injury or inflammation. And the PGs made by this COX-2 are the main drivers of inflammation, the pain, the swelling, the heat.
The things we're trying to treat with the NSAID in the first place.
Exactly. So the ideal drug would just hit COX-2, right? Leave COX-1 alone.
Seems logical. But nature's rarely that simple.
Precisely. The sources highlight a key nuance. While COX-2 is mainly inducible and inflammatory, it's also constitutively present in some important places.
Oh, where?
In the brain, for one. Also in the juxtaglomerular cells in the kidney, those are crucial for blood pressure control, and in the developing fetus.
So even the bad COX-2 has some essential normal jobs.
It does. Which means if you inhibit COX-2 systemically, you risk disrupting those normal functions too. It complicates the whole selective inhibition strategy immensely.
Okay, let's look at how they inhibit, because aspirin is different here, isn't it?
Massively different. Most traditional NSAIDs, ibuprofen, naproxen, diclofenac, etc., are competitive reversible inhibitors.
Meaning?
They basically fight with arachidonic acid for the parking spot, the active site on the COX enzyme. They bind, block it for a while, then let go. Their effect lasts as long as the drug is around, governed by its half-life. Once the drug is cleared, the enzyme works again.
Standard competition. But aspirin.
Aspirin plays dirty. It's an irreversible inhibitor.
How does it do that?
It chemically modifies the enzyme. It transfers an acetyl group onto a specific spot, a serine residue, right in the COX active site. This permanently breaks that enzyme molecule, covalently bonded.
Permanently. So the enzyme is just done.
That specific molecule is, yes. The only way the body can get COX activity back after aspirin is to make brand new enzyme protein from scratch.
And that's especially important for platelets, right? You mentioned that connection.
Absolutely critical. Platelets are unique. They don't have a nucleus.
No nucleus, so no instructions to make new stuff.
Exactly. They can't synthesize new proteins, including new COX-1 enzyme. So when aspirin acetylates the COX-1 in a platelet, that platelet is functionally crippled for its entire lifespan.
Which is how long?
About 7 to 10 days, long after the aspirin itself has been cleared from your blood. This is why even a tiny, low dose of aspirin has such a profound and lasting anti-platelet effect. Perfect for prevention. Okay, so now we bridge from mechanism to clinical reality. And the big takeaway from the source material here is stark. The benefits and the major side effects of NSAIDs are two sides of the same coin. Meaning they both stem directly from inhibiting prostaglandin synthesis. You can't really separate them. Blocking the PGs that cause inflammation and pain often means you're also blocking the ones that protect your stomach or kidney.
A fundamental trade-off baked into the mechanism.
Yeah.
Hashtag tagged hey. Beneficial actions. The clinical target. All right, let's start with the good stuff. The reason we use them. Analgesia, pain relief. If they're not opioids, how do they stop pain?
They primarily work by stopping hyperalgesia.
Hyperalgesia.
Yeah.
Increased sensitivity to pain.
Exactly. Prostaglandins themselves don't usually start the pain signal, but they make the nerve endings much more sensitive to other pain-provoking stimuli. Things like bradykinin, TNF-alpha, interleukins. PGs essentially lower the pain threshold.
They turn up the volume on the pain signal.
Perfect analogy. NSAIDs block the production of those PGs, so they prevent that sensitization. They turn the volume back down.
Okay, so it's targeting the amplification. Mostly peripheral.
Primarily peripheral, yes, and largely by inhibiting that induced COX-2 at the site of injury. But there's also a central component. NSAIDs inhibit PG synthesis within the spinal cord and brain, too.
So they raise the pain threshold centrally as well.
Correct. Which helps explain why they work well for pain associated with inflammation or tissue damage, but maybe not so well for severe visceral pain, like ischemic pain, which has different drivers.
Makes sense. Okay, next benefit. Antipyresis. Fever reduction. I always found it interesting. They only lower high temperature. They don't make you cold if you're normal.
That selectivity is tied to the mechanism. Fever happens when pyrogens, things like bacterial toxins or our own interleukins and TNF-alpha, tell the hypothalamus in the brain to make more PGE2.
Right, the thermostat center.
Exactly. That PGE2 then acts locally to raise the body's temperature set point. You get a fever. NSAIDs work by blocking the production of that fever-inducing PGE2 in the hypothalamus.
So they stop the signal telling the thermostat to go up. They don't directly cool you down.
Precisely. They block the pyrogen's action on PGE2 synthesis. But if you were to inject PGD2 directly into the brain, NSAIDs wouldn't stop the resulting fever.
Clever. And which KOX is involved there?
It seems to be KOX2 primarily, or maybe a variant called KOX3, which is particularly sensitive. This becomes relevant when we talk about paracetamol later.
Okay. Benefit number 3, anti-inflammatory action. This is in the name, NSAID.
This is mostly due to inhibiting KOX2, which, as we said, gets ramped up at the inflammation site and churns out inflammatory PGs. Block KOX2, you reduce those PGs, you reduce inflammation.
And it's not the whole picture for inflammation, is it?
Definitely not. Big caveat here. PGs are just one piece of the inflammatory puzzle. NSAIDs, by inhibiting KOX, don't touch other important mediators like leukotrienes or platelet activating factor or various cytokines.
So their anti-inflammatory power is limited compared to, say, steroids.
Correct. Corticosteroids have much broader effects, though some NSAIDs might have extra tricks up their sleeve.
Like what?
The sources suggest some, like nimsolide perhaps, might have additional non-COX actions, maybe inhibiting adhesion molecules so white blood cells can't stick as easily, or reducing damaging superoxide radicals, or even stabilizing certain cell membranes. Secondary effects.
Interesting. Okay, 4th benefit, antithrombotic action. This seems specific, especially for aspirin.
Very specific and dose-dependent. It's all about balance. Remember, traditional NSAIDs block both TXA2 from platelets, which makes them clump together, pro-aggregatory, COX1-driven, and PGI2 from the blood vessel wall, which stops clumping, anti-aggregatory, partly TOX2-driven.
So you need to inhibit the clumping factor more than the anti-clumping factor.
Exactly. You want the inhibition of TXA2 to win out. Low-dose aspirin is perfectly designed for this.
How so?
That small dose gets absorbed, goes through the liver's portal vein first. It encounters platelets there and irreversibly knocks out their COX1 before the liver can quickly deacetylate and inactivate the aspirin itself.
Ah, the first pass effect works in its favor.
Precisely. It ensures maximum platelet inhibition with minimal systemic drug exposure, giving that sustained antiplatelet effect needed for preventing heart attacks and strokes.
Clever pharmacology. Lastly, a very specific use, ductus arteriosus closure.
Right. This is a neat example in neonatology. In the fetus, PGE2, mostly made by KOX2, keeps a blood vessel called the ductus arteriosus open, which is vital before birth.
Okay.
Normally, it closes on its own shortly after birth, but if it stays open, patent ductus arteriosus, or PDA, it causes problems. Small, carefully timed doses of indomethacin, or sometimes aspirin, can help close it by inhibiting that local PGE2 production.
But this implies a danger too.
A huge danger. If you give NSAIDs to a woman late in pregnancy, you risk causing premature closure of that ductus in utero.
Which would be bad.
Catastrophic. It leads to severe pulmonary hypertension in the newborn. That's why NSAIDs are generally a big no-no near term. #B, shared toxicities, the unintended consequences.
All right, that brings us to the dark side. The price of inhibiting PGs. Let's start with the most infamous one. Gastric mucosal damage, ulcers, bleeding.
This is the classic textbook NSAID toxicity, and it's a direct hit on COX1.
Housekeeping enzyme.
Exactly. Those protective prostaglandins, PGE2 and PGI2, are made by KOX1 in the stomach lining. They do two crucial things. They dial down stomach acid secretion, and they ramp up the secretion of protective mucus and bicarbonate.
Defense mechanisms.
Right. When you block COX1 systemically with an NSAID, those defenses crumble. Less mucus, less bicarbonate, maybe more acid. The stomach lining becomes vulnerable.
And you mentioned the drug's acidic nature makes it worse.
It does. It adds a local injury component through ion trapping. Take aspirin, it's a weak acid. In the very acidic stomach fluid, it's mostly unionized, so it can easily slip into the stomach lining cells.
Okay.
But inside the cell, the pH is neutral, around 7.1. So the aspirin molecule immediately ionizes, gains a charge, and now it can't easily diffuse back out. It gets trapped inside the cell at high concentrations.
And damages the cell from within.
Causes local damage, makes the cell leaky to acid, H plus back diffusion. It's a double whammy. Systemic loss of PG protection plus direct local injury.
Ouch. No wonder stomach pain, erosions, ulcers, and that slow, steady blood loss are so common.
Yeah, that occult blood loss can average around 5 milliliters a day with anti-inflammatory doses. Significant over time. Thankfully, there are ways to mitigate this.
Ow.
While paracetamol doesn't cause this, selective COX-2 inhibitors are generally safer on the stomach, or you can co-prescribe drugs like misoprostol, a PG analog, or proton pump inhibitors, PPIs, to either replace the PGs or shut down acid production.
Got it. Toxicity number 2. Bleeding beyond the stomach.
This stems from inhibiting platelet TXA2 synthesis, also a THOX1 job. Less TXA2 means platelets don't stick together as well, so bleeding time gets longer.
Is this significant for everyone?
Therapeutic doses of most traditional NSAIDs will prolong bleeding time somewhat. Aspirin's effect is the most dramatic and lasts for days due to irreversibility. It's a major concern during surgery or if someone's already on anticoagulants like warfarin.
Okay. Next up, renal effects, kidney problems, sodium and water retention. This seems less obvious.
It's subtle in healthy people but can be a huge problem in patients with compromised circulation. Think heart failure, CHF, cirrhosis of the liver, or pre-existing kidney disease.
Why them specifically?
In those situations, blood flow to the kidneys is already stressed. The kidneys then rely heavily on locally produced PGs, mainly PGE2 from CYOX-1 and CYOX-2, to keep blood vessels dilated and help excrete salt and water, partly by opposing the action of ADH, antidiuretic hormone.
So PGs are like a safety valve for the kidney under stress.
Exactly. Now, you give an NSAID. It blocks both COX-1, reducing renal blood flow further, and it blocks that constitutive COX-2 in the juxtaglomerular cells, which directly causes the kidney to hold on to sodium and water.
Double hit on the kidney too.
Right. The clinical impact is huge. NSAIDs can make diuretics less effective, make blood pressure medications work less well. You can see swelling, pedal edema, blood pressure can shoot up, and it can even push someone into full-blown heart failure.
And chronic use.
Chronic, heavy use, especially of combination products, is linked to a specific type of kidney damage called analgesic nephropathy, potentially leading to irreversible failure. It's serious.
Okay. We touched on dysfunction of parturition delaying labor.
Yeah, simply because PGs are needed to get labor started and keep it going. Block them near term, you risk delaying or prolonging labor. Again, why paracetamol is generally preferred late in pregnancy.
And the last big one? Asthma and anaphylactoid reactions, especially with aspirin.
This is a strange one. It's not a true allergy. It's non-immunological. It happens in susceptible people, often those with underlying asthma and nasal polyps.
What's the theory?
The main hypothesis, though it's not definitively proven, is called pathway shunting or diversion. When you suddenly block the COX pathway, the raw material, arachidonic acid, might get funneled excessively down the other major pathway, the lipoxygenase LOX pathway.
And that pathway makes
Leukotrienes, LTs. And some leukotrienes are incredibly potent bronchoconstrictors that they clamp down the airways. So blocking COX leads to an overproduction of LTs, triggering an asthma attack.
a biochemical detour causing airway crisis.
Potentially. It means you absolutely must ask about aspirin or NSAID sensitivity in anyone with asthma before prescribing.
Okay, let's zero in on aspirin again, the original. We know it's a weaker pain reliever than opioids, maybe 600 milligrams aspirin equals 60 milligram codeine, roughly. But for anti-inflammatory effects, you need much higher doses.
That's right. The analgesic dose is relatively low, but to get significant anti-inflammatory action, like for rheumatic fever, you're talking chronic doses of 3 to 6 grams per day. Grams, not milligrams.
That's a lot. And at those high doses, it starts having widespread effects, right? Metabolic effects.
High-dose aspirin does something called uncoupling oxidative phosphorylation, especially in skeletal muscle. It basically makes the cell's energy production less efficient, ramps up metabolism.
What does that lead to?
Increased oxygen consumption, increased glucose use, potentially depleting the liver's glycogen stores. The body has to work harder just to function normally. It can even contribute to the fever seen in aspirin toxicity.
And the breathing effects, the acid-base balance. This sounds critical for understanding toxicity.
Absolutely critical. Initially, at therapeutic high doses or early toxicity, aspirin directly stimulates the respiratory center in the brain. You start breathing faster and deeper hyperventilation.
Which blows off CO2.
Exactly. Lower CO2 leads to respiratory alkalosis. Your blood pH goes up. The kidneys try to compensate quickly by dumping bicarbonate, HCO3 into the urine. Most adults on chronic high-dose aspirin live in this state of compensated respiratory alkalosis.
But in serious poisoning, that flips.
Dramatically. In severe toxicity, two things happen. First, the metabolic effects really kick in. That uncoupling generates lots of lactic acid, pyruvic acid, other organic acids. You get a profound metabolic acidosis.
Okay, acid buildup.
Second, at very high toxic doses, aspirin eventually depresses the respiratory center. So now you can't even blow off CO2 to compensate. You end up with this severe, often mixed, acid-base catastrophe. Respiratory depression plus metabolic acidosis.
Nasty combination.
Right.
And why children are more vulnerable.
They often seem to develop the metabolic acidosis component earlier and more severely than adults. It makes managing pediatric aspirin poisoning incredibly challenging.
We already discussed the GI toxicity mechanism, ion trapping, plus loss of PG protection. It's particularly bad for aspirin.
It really is the gold standard for NSAID-induced GI damage because of that potent combination. And it highlights why things like buffered aspirin, while maybe slightly easier on the stomach initially, don't really reduce the risk of serious ulcers or bleeding long-term. The systemic effect is still there.
What about the signs of reaching that high therapeutic or early toxic dose? Salicylism.
Salicylism is the classic cluster of symptoms: dizziness, ringing in the ears, tinnitus, maybe some hearing impairment. It tells you you've hit the dose needed for strong anti-inflammatory effects, but you're also bordering on toxicity.
And full-blown acute poisoning.
That's a medical emergency, especially in kids. In adults, taking more than maybe 15 to 30 grams can be fatal. You see high fever, dehydration, confusion, delirium, seizures, coma, and that lethal acid-based disturbance. Requires intensive care immediately.
And we absolutely have to mention Ray's syndrome again.
Yes, this is non-negotiable. The strong association between aspirin use during viral infections, chickenpox, influenza, and the development of this rare but devastating liver failure and brain swelling, hepatic encephalopathy, in children.
Which led to
Aspirin being essentially banned for pediatric use in many countries, including India and the UK, for fever and pain. The risk, though small, is just too catastrophic. Use paracetamol or ibuprofen instead in kids.
So, given all these risks, GI, bleeding, acid base, Ray, where does aspirin still fit in besides low-dose prevention?
It's still a first-line drug for acute rheumatic fever using those high anti-inflammatory doses, 4 to 5 gr day. It helps symptoms dramatically, though it doesn't prevent the heart valve damage.
Okay.
And low-dose aspirin, 80 to 100 mg a day, is crucial starting from the second trimester to help prevent preeclampsia in high-risk pregnancies, likely by balancing PGs involved in placental function. Also sometimes used investigationally for things like familial colonic polyposis. It still has unique roles. #B, paracetamol, acetaminophen.
Okay, let's switch gears to the other absolute giant. Paracetamol, or acetaminophen as it's known in the U.S. Where did it come from?
It's actually the active metabolite of an older drug called phenacetin, which got banned because of kidney toxicity and cancer risk. Paracetamol itself was found to be effective and much safer.
And its mechanism is unique, right? That's the key to its safety profile.
Absolutely. This is high-yield knowledge. Paracetamol is a great central analgesic and antipyretic. It works well in the brain to raise the pain threshold and reduce fever, likely by inhibiting COX there.
But crucially,
it has almost no significant peripheral anti-inflammatory action. Even at high doses, it doesn't really reduce swelling or inflammation in the body tissues like aspirin or ibuprofen do.
why the difference? Why brain, but not periphery?
The leading theory, as we touched on, involves the chemical environment. It's thought that paracetamol's ability to inhibit COX is severely hampered by high levels of peroxides.
And you find lots of trioxides where?
At sites of inflammation, they're generated as part of the inflammatory process, but peroxide levels are thought to be much lower in the central nervous system.
So the environment in the brain allows it to work on COX there, but the inflammatory soup in the periphery shuts it down.
That's the hypothesis. It explains why it's good for headache or fever, central, but not so much for a swollen ankle, peripheral inflammation. It might be acting on that COX3 variant or just COX in a low peroxide setting.
And this lack of peripheral action is why it's so much safer in certain ways.
Exactly. Because it barely touches peripheral TOX, especially COX1, it completely sidesteps the major NSI toxicities.
Like what?
No effect on breathing, no messing with acid-base balance, no uncoupling metabolism, no effect on platelets or blood clotting, and most importantly, virtually no gastric irritation or risk of ulcers and bleeding.
That's huge.
It's why paracetamol is generally the first choice for simple pain or fever, safe for all age groups, including infants, safe in pregnancy, safe for patients with ulcers. It's the go-to baseline analgesic antipyretic.
But, and it's a big but, this very safety leads to its one major danger: acute poisoning. Overdose.
Tragically, yes. Because it's seen as so safe and is available everywhere, massive overdoses, accidental or intentional, are incredibly common, especially with kids accessing liquid formulations.
And overdose is uniquely dangerous with paracetamol. How much is too much?
The danger zone starts around 150, 250 milligrams per kilogram of body weight. A single ingestion of maybe 10, 15 grams in an adult can be fatal if untreated.
What happens in an overdose? What's the mechanism of liver damage?
Okay, this is critical to master. Normally, the body gets rid of paracetamol mainly by conjugating it, sticking sugars, glucuronidation, or sulfates onto it, making it water-soluble for excretion.
Standard detox pathways.
Right. But in a massive overdose, those main pathways get completely swamped. They're saturated. The liver can't keep up.
So the drug backs up.
And the excess drug gets forced down a minor metabolic pathway, handled by cytochrome P450 enzymes. This pathway generates a small amount of a highly reactive toxic intermediate metabolite,
What's it called?
N-acetylp-benzoquinoamine, NABQI for short.
NABQI. Okay, that sounds bad.
It is. Normally, the liver immediately neutralizes this NABQI using its stores of a protective antioxidant called glutathione. Glutathione essentially mops it up safely.
But in overdose,
The sheer amount of NABQI being produced completely overwhelms and depletes the liver's glutathione stores. Once glutathione runs out, trouble.
what does the NABQI do then?
With no glutathione left to neutralize it, the highly reactive NABQI starts attacking liver cell proteins directly, binding to them covalently, irreversibly.
Killing the liver cells.
Causes massive cell death, particularly in the center of the liver lobules, central lobular necrosis. This leads to acute liver failure, which can be fatal within days. It's a threshold effect. Once glutathione is gone, the damage starts and progresses rapidly.
Terrifying. So treatment has to be fast.
Extremely time critical. First, you try to stop absorption, gastric lavage maybe. Definitely activated charcoal. Supportive care is vital. But the specific life-saving antidote is N-acetylcysteine, or NAC.
And acetylcysteine, how does that work?
NAC works primarily by acting as a precursor for glutathione synthesis. It essentially provides the raw materials for the liver to rapidly replenish its depleted glutathione stores.
Ah, it helps the liver rebuild its defenses to mop up the remaining NABQI.
Exactly. It might also directly detoxify some NABQI itself, but the key is restoring glutathione before irreversible cell binding occurs.
Which means you have to give it early.
Absolutely. The sources are clear. NAC is highly effective if started within 8-10 hours of ingestion. Its effectiveness drops off dramatically after that. If you wait longer than 16, maybe 24 hours, the liver damage is likely already done and NAC won't help much. The window is critical.
That urgency really underscores the danger. And the FDA took action.
Yeah, back in 2009, partly due to overdose concerns, the FDA recommended limiting the maximum single adult dose in over-the-counter products to 650 milligrams and the maximum total daily dose to 2,600 milligrams, down from 4,000 milligrams, just to build in a greater margin of safety.
Okay, beyond aspirin and paracetamol, there's a whole roster of other traditional NSAIDs. Let's start with the propionic acid derivatives. This includes the really common ones, ibuprofen and naproxen.
Right, these are probably the next most frequently used class after paracetamol. They are, like most non-aspirin NSAIDs, competitive, reversible COX inhibitors.
And generally better tolerated than aspirin.
Generally, yes. They tend to cause less severe stomach irritation, erosion, and bleeding compared to aspirin, although the risk is definitely still there, especially with higher doses or chronic use. Ibuprofen is often pointed to as perhaps the safest traditional NSAID overall.
Which is why it's available over the counter. Good for things like period pain.
Very effective for dysmenorrhea, yes. But the single most important clinical pearl about ibuprofen is its interaction with low-dose aspirin. This is critical for patients on aspirin for their heart.
Explain that again. Why is it a problem?
Because ibuprofen binds reversibly to the same spot on COX-1 that aspirin needs to bind irreversibly to exert its antiplatelet effect.
So ibuprofen gets in the way.
It physically blocks aspirin from getting access to that critical serine residue. If someone takes ibuprofen shortly before or concurrently with their daily low-dose aspirin, the ibuprofen essentially protects the platelet COX-1 from aspirin's permanent acetylation.
And the result?
It completely cancels out aspirin's antiplatelet and cardioprotective benefit for that dosing interval. Repeatedly doing this could leave the patient unprotected. They need careful advice on timing. Take aspirin first, wait a while, then take ibuprofen, or better yet, avoid regular ibuprofen if possible.
Crucial interaction. Okay, how does naproxen compare within this class?
Naproxen is generally considered a bit more potent as an anti-inflammatory than ibuprofen. Its main distinguishing feature is a much longer half-life, around 12 to 16 hours.
Which means less frequent dosing.
Right, usually just twice a day, which can be good for compliance in chronic conditions like arthritis. It also seems to be a particularly strong inhibitor of leukocyte migration, which might contribute to its effectiveness in acute gout.
And its cardiovascular risk profile.
Compared to some other non-aspirin NSAIDs like diclofenac or the oxicams, naproxen is generally thought to carry a lower risk of thrombotic events. Regular use does effectively suppress platelet function, more so than diclofenac.
Okay. What about ketoprofen or flurbiprofen?
Similar efficacy to ibuprofen, really, but maybe with a slightly higher incidence of side effects. Ketoprofen might have some extra actions like stabilizing lysosomes or maybe inhibiting the LOX pathway a bit. Flurbiprofen is found a niche mainly in eye drops for ocular inflammation after surgery.
Got it. Moving on to the phenamates class, mefenamic acid is the main one.
Yes. Mefenamic acid is interesting. It inhibits PG synthesis, but it might also directly block some PG actions. It's generally considered a weaker anti-inflammatory compared to the propionics.
Any key side effects?
The most characteristic one is diarrhea, which seems to be dose-related. Like ibuprofen, it's also quite commonly used for dysmenorrhea.
Okay. Next class, enolic acid derivatives, the oxicams, piroxicam and tanoxicam.
The defining feature of the oxicams, especially piroxicam, is their incredibly long plasma half-life. Piroxicams is around 45-50 hours, almost 2 days.
Wow, so genuinely once-a-day dosing.
Yes, which is very convenient for chronic conditions like osteoarthritis or rheumatoid arthritis. It's also quite potent anti-inflammatory and may have some additional antioxidant effects, decreasing free radicals and inhibiting white cell movement.
But that long half-life must have a downside.
Big downside. It means the drug accumulates significantly with repeated dosing, especially in the elderly or those with even mild kidney issues. This leads to a relatively higher risk of side effects overall, particularly GI problems like ulcers, compared to shorter-acting NSAIDs. So it's convenient, but generally not a first-choice drug due to the toxicity profile.
Makes sense. All right, the acetic acid derivatives. This group includes some potent players: indomethacin, ketorolac, diclofenac, and nabumetone. Let's start with indomethacin.
Indomethacin is one of the most potent anti-inflammatory agents we have among the NSAIDs, also a strong antipyretic, but
There's always a but with the potent ones.
huge but. Its use is really limited by a very high incidence of side effects, affecting up to 50% of patients. GI issues are common, but the CNS side effects are particularly notable.
Like what?
Severe frontal headache is almost characteristic. Dizziness, confusion, disorientation, even depression or psychosis can occur. It's not a well-tolerated drug for routine use.
So it's kept in reserve.
Strictly a reserve drug, used for severe inflammatory conditions where other agents fail, like ankylosing spondylitis, acute gout attacks. Also used for certain types of fever associated with cancers. And as we mentioned, it's still a key drug for closing a patent ductus arteriosus in newborns because of its potency.
Okay. Now, ketorolac. This one's known for pain relief, right?
Phenomenal analgesic. Ketorolac is arguably the most potent analgesic among the NSAIDs. Its pain-relieving efficacy, especially for moderate to severe postoperative pain, is often compared to that of morphine.
Without the opioid side effects.
Exactly. No respiratory depression, sedation, or addiction potential. It's available as an injection, IMIV, which makes it incredibly useful in acute settings like post-op recovery or for severe pain like renal colic or acute musculoskeletal injuries.
But there's a catch, a time limit.
A strict time limit. Because of a significantly high risk of serious GI bleeding and kidney damage, ketorolac use by all routes combined should absolutely not exceed 5 days continuously. It's for short-term acute pain management only, not for chronic conditions.
Got it. Diclofenac sodium, this one is everywhere, used widely. Any unique features?
Diclofenac is very effective, similar in potency to naproxen. The sources suggest it has a slight preference for inhibiting TOX2 over QX1.
So maybe a bit easier on the stomach than truly non-selective ones?
Theoretically, perhaps, but clinically it still carries significant GI risk. Importantly, because it spares TOX1 to some extent, its antiplatelet effect is not very strong or reliable compared to aspirin or naproxen.
Okay, and pharmacokinetics.
This is interesting. Diclofenac has a really short plasma half-life, only about 2 hours, but it seems to penetrate well into synovial fluid in joints and persists there much longer, so you get extended action where you often need it in arthritis.
But that combination COX2 preference, weak antiplatelet effect, raises the cardiovascular flag again.
It does. Like other NSAIDs that don't adequately inhibit platelet COX1, diclofenac is associated with an increased risk of heart attack and stroke. It's generally placed in a higher CV risk category than naproxen or ibuprofen. That risk needs careful consideration, especially with long-term use.
Okay. Last one in this group, nebumetone. This is a prodrug.
Yes, nebumetone itself is inactive. It needs to be absorbed and then metabolized by the liver into its active form, which is called 6-MNA, 6-methoxy-2-naphthalicitic acid.
Does that offer any advantage?
The main proposed advantage is potentially reduced direct gastric irritation. Because the parent drug is inactive when swallowed, it might cause less local damage before absorption compared to other oral NSAIDs. Clinical data suggests a lower incidence of ulcers, though not zero. It also has a long half-life, around 24 hours, allowing once-daily dosing.
Interesting approach. Just a quick word on the pyrazolones.
Mostly historical. Drugs like phenylbutazone and antipyrine were potent but had devastating side effects, particularly bone marrow suppression, causing things like agranulocytosis, loss of white blood cells, and aplastic anemia. They're pretty much banned or obsolete globally now.
Any exceptions?
Propionate is still found in some countries, often in fixed-dose combination products like Ceridon, usually just for short-term use as an analgesic antipyretic. But the whole class carries a legacy of severe toxicity concerns.
Okay, this brings us to the coxibs. Celecoxib, rofecoxib, etacoxib. These are supposed to be the magic bullet, right?
Yeah.
All the anti-inflammatory benefits of NSAIDs without the stomach bleeding. What went wrong?
The theory was so seductive, we knew COPS-1 did housekeeping and COX-2 did inflammation, mostly. So design a drug that only hits COX-2. You block the inflammation, spare the stomach protection, perfect.
And early on, it looked like it worked.
It did. Early trials showed significantly fewer ulcers and serious GI bleeds compared to traditional NSAIDs like naproxen or ibuprofen. They seemed like a huge step forward for patients at high GI risk.
But then the cardiovascular problems emerged. The disaster, as you called it. What was the mechanism?
It came back to that delicate balance between PGI2 and TXA2, and the fact that CX2 isn't just about inflammation.
Explain the balance again.
Okay. Platelets use COX1 to make thromboxane A2, TXA2, which promotes clotting and vasoconstriction. The lining of blood vessels, endothelium, uses both COX1 and COX2 to make prostacyclin, PGI2, which prevents clotting and causes vasodilation. Normally, these two forces are in balance.
Okay. Push and pull.
Now, introduce a selective COX2 inhibitor. It drastically reduces PGI2 production by the endothelium because it inhibits endothelial COX2. But because it spares COX1, it leaves platelet TXA2 production completely untouched.
So you've taken away the stop clotting signal, but left the start clotting signal running full blast.
Exactly. You create a prothrombotic imbalance, you shift the whole system towards clotting and vasoconstriction, and the clinical consequences were devastating.
The VIOX story.
Rofecoxib, VIOXX. The VIGOR trial compared it to naproxen. Alarm bells went off when they found a 4 to 5-fold higher rate of myocardial infarction, heart attack, in the VIXX group.
4 to 5 times higher.
Yes. Then the APPROVE trial, designed to look at colon polyps, also found a significantly increased risk of heart attack and stroke with VIOXX, leading to its voluntary withdrawal from the market worldwide in 2004. A massive event in pharmacology.
And it wasn't just VOXX.
No. Valdecoxib Bextra was withdrawn in 2005 due to similar cardiovascular risks, plus concerns about severe, potentially fatal skin reactions like Stevens-Johnson syndrome. Its injectable prodrug, paracoxib, carries similar warnings.
What about celecoxib, Celebrex? It's still available?
Celecoxib is less selective for COX2 than rofecoxib was. However, a large prevention trial, the APC trial, looking at colon polyps, was also stopped early because patients taking celecoxib had about a 2.5-fold higher risk of major cardiovascular events compared to placebo. It carries strong warnings now.
And etoricoxib, the most selective one.
Etoricoxib has the highest COX2 selectivity. Trials like METAL compared it to diclofenac and found roughly similar cardiovascular risk, which, as we discussed, isn't necessarily low for diclofenac either. The bottom line is, all coxibs carry an increased CV risk compared to placebo, and likely compared to naproxen. The class effect seems real.
Beyond the massive CV risk, were there other nagging doubts about the coxibs even before the big trials?
There were a few. One was whether they'd be quite as effective across the board as traditional NSAIDs, since maybe IX1-generated PGs do play some small role in inflammation or pain that the coxibs would miss.
Okay.
Another interesting point was about ulcer healing. It turns out that when an ulcer forms, the stomach lining actually induces COX2 locally, and the PGs produced seem to help the healing process. So inhibiting TOX2 might paradoxically delay ulcer healing, even if it prevents new ones.
Fascinating. Nature's repair mechanisms are complex.
Yeah.
And the kidney risk. Did selectivity help there?
Unfortunately, no. Remember, the kidney uses constitutive COX2 in those juxtaglomerular cells to regulate salt and water balance. Coxibs inhibit this just like traditional NSAIDs do.
So same risk of edema, hypertension, heart failure precipitation.
Essentially, same renal risks apply. Selectivity offered no advantage there.
So after all this,
Yeah.
where do coxibs stand now? What's the professional guidance?
Extremely cautious. They are absolutely not first-line agents. They should only be considered for patients who are at high risk for serious GI complications, like bleeding ulcers, and who have failed or cannot tolerate traditional NSAIDs, plus gastroprotection, like a PPI.
High GI risk, low CV risk profile needed.
Precisely. And even then, the rule is lowest effective dose for the shortest possible duration. They are generally contraindicated or should be used with extreme caution in anyone with established cardiovascular disease, stroke history, uncontrolled hypertension, or heart failure.
What about combining a coxib with low-dose aspirin? Seems logical if you need heart protection and gut protection.
It seems logical, but the data suggests it's generally a bad idea. Adding low-dose aspirin to a coxib largely negates the GI safety advantage of the coxib alone. You end up with a significantly higher risk of ulcers and bleeding than with the coxib by itself, plus you still have the underlying CV risk from the coxib. It's usually not the right strategy. Better to use a traditional NSAID like naproxen plus a PPI if both GI and CV risks are concerns.
Okay, we've gone through the mechanisms, the benefits, the risks, the specific drug classes. Now let's synthesize this for clinical decision-making. The sources suggest that for many conditions, the efficacy differences between various NSAIDs aren't actually that huge.
That's often true, especially for pain relief or basic inflammation. One might work slightly better for one person than another, but there's no single best NSAID for everyone in terms of pure power.
So the choice really comes down to safety and the patient's individual risk factors.
Absolutely. Selection becomes primarily an exercise in risk stratification and mitigation. You have to match the drug's known liability profile to the patient's vulnerabilities, their age, their gut health, kidney function, cardiovascular history, other medications.
It's tailoring the choice. Okay, let's run through some scenarios. Scenario 1, mild pain, maybe a headache, minor sprain, not much inflammation. What's the approach?
Start simple and safe. Paracetamol is usually the first choice. Or perhaps low-dose ibuprofen if some anti-inflammatory effect might be helpful. Lowest risk options first.
Scenario 2, acute severe pain. Post-operative pain, maybe renal colic, a bad musculoskeletal injury, needs strong, fast relief.
Here the injectable options shine. Ketorolac is excellent for its opioid-like analgesia, but remember that strict 5-day limit. Injectable diclofenac is another strong option. Or, if oral is feasible, a higher dose of a propionic acid derivative like naproxen or ibuprofen could work.
Scenario 3, the patient with chronic arthritis who needs long-term anti-inflammatory treatment but has a history of stomach ulcers or significant GI intolerance. High GI risk.
This is the primary niche where a selective EOX2 inhibitor, a coxib, might be considered, provided the patient has a low cardiovascular risk profile. Use the lowest dose, shortest time.
And if a coxib isn't suitable or desired.
The alternative is to use a traditional NSAID, preferably one considered slightly safer on the gut, like naproxen maybe, but always co-prescribed with a gastroprotective agent, usually a proton pump inhibitor, PPI, like omeprazole. Paracetamol might help with pain, but won't provide the anti-inflammatory effect needed for arthritis control.
Scenario 4, patient with asthma who has had a bad reaction, bronchospasm, hives, to aspirin in the past. High risk for hypersensitivity.
Tread very carefully. Paracetamol is generally safe. If an NSAA is absolutely required, the theory suggests that drugs with less impact on the COX-LOX balance might be safer. Nimesulide, where available, or a selective COX-2 inhibitor like celecoxib might be tolerated, as they often don't cross-react. But this needs specialist assessment and extreme caution, maybe even a supervised challenge dose.
Okay. Scenario 5, the patient with significant cardiovascular risk history of heart attack, stroke, angina, uncontrolled hypertension, heart failure.
Big red flags here. Selective KOX2 inhibitors should generally be avoided entirely. Diclofenac also carries a higher risk. The evidence suggests that naproxen might be the relatively safest traditional NSAID in this group from a thrombotic standpoint, possibly followed by ibuprofen. But the absolute rule is use any NSAID other than low-dose aspirin for secondary prevention, only if essential, at the lowest possible dose and for the shortest possible duration. Minimize exposure.
Let's quickly recap for special populations. Pediatrics.
Aspirin is out due to Ray's syndrome. Paracetamol and ibuprofen are the mainstays. Naproxen is also approved for some uses in older children. Stick to these well-evaluated options.
Pregnancy.
Paracetamol is the safest analgesic antipyretic throughout pregnancy. Low-dose aspirin has specific roles, like preeclampsia prevention, but needs careful intubation. All other NSAIDs, especially traditional ones and coxibs, should generally be avoided, particularly in the third trimester, due to the risk of premature ductus arteriosus closure and potential effects on labor.
What about combination analgesic products? You see them everywhere. Paracetamol plus ibuprofen, aspirin plus paracetamol. Are they better?
The evidence for superior efficacy or safety of these fixed combinations over single agents used correctly is actually pretty weak. Yes, you get additive analgesia, but there's often a ceiling effect. Taking both doesn't give much more relief than the maximum dose of one, and you expose a patient to the risks of both drugs.
So, generally not recommended.
Generally, it's better pharmacology to optimize the dose of a single appropriate agent first. If that fails, then consider adding a second agent with a different mechanism, rather than just another NSAI or paracetamol. The combinations mostly offer convenience, not proven superiority, and can lead to accidental overdose if patients aren't careful about total daily intake from different sources.
But combining an NSAI or paracetamol with an opioid like codeine, that's different.
That's a fundamentally different strategy, yes, because opioids work via completely different receptors and pathways. Adding one, like codeine or tramadol, to an NSAID or paracetamol does provide significant additional pain relief, getting you beyond the ceiling effect of the non-opioid alone.
But it comes with opioid baggage.
Absolutely. You introduce all the opioid-related side effects, constipation, nausea, drowsiness, dizziness, and crucially, the risk of tolerance, dependence, and abuse, even with weaker opioids like codeine. So that combination is reserved for more severe pain and requires much closer monitoring.
Let's touch on topical NSAID gels, patches, like diclofenac gel. What's the thinking there?
The rationale is simple. Deliver the drug right where it's needed, in the painful joint or muscle, while minimizing the amount that gets into the bloodstream and causes systemic side effects.
Does it work?
It can. You can achieve quite high concentrations of the drug in the tissues, just under the skin, maybe 4 to 6 millimeters deep. Systemic absorption is usually very low, often less than 10–15% of what you'd get from taking the same dose orally. This also bypasses the liver first pass metabolism.
So, much lower risk of GI or kidney problems.
Theoretically, yes. The efficacy can be variable. It works better for superficial joints like knees and hands than for deep structures like hips. But for mild to moderate osteoarthritis pain, especially in the knee or hand, guidelines often recommend trying topical NSAIDs first or as an add-on therapy, precisely because of the improved safety profile.
Good option for localized pain. Finally, you mentioned an outlier, Nefopam. What's its story?
Nefopam is interesting because it's a centrally acting, non-opioid analgesic, but it does not work by inhibiting prostaglandin synthesis. Its exact mechanism isn't fully clear, but it seems to involve neurotransmitter pathways.
So useful when NSAIDs are contraindicated.
Potentially, yes. If someone absolutely cannot take NSAIDs or paracetamol, Nefopam might be an option for certain types of persistent pain. However, it's not without its own side effects, things like dry mouth, sweating, nausea, dizziness, tachycardia, fast heart rate, due to its anticholinergic and sympathomimetic properties. It's not a first-line drug, more of a niche alternative.
Wow, this has been a truly comprehensive deep dive. We've really unpacked the layers of complexity behind these seemingly simple drugs.
It really drives home the central theme, doesn't it? The benefits we seek from NSAIDs, the relief of pain, fever, inflammation, are fundamentally mechanistically linked to their main toxicities in the gut, the kidneys, the cardiovascular system. It all comes back to inhibiting prostaglandin synthesis via COX enzymes.
And mastering this field means understanding those nuances, the COX1 versus COX2 selectivity and its limitations, the difference between reversible and irreversible inhibition, the pharmacokinetic properties like half-life, and how those translate into specific risks for specific patients.
Absolutely. The history, the mechanism, those hard lessons learned from VIOXX, the critical timing for treating paracetamol overdose. It shows that the line between a therapeutic success and a serious, even fatal adverse event can be incredibly fine. It hinges on precise knowledge, dose, duration, patient factors, and which enzyme isoform you're targeting or sparing.
Which leads us perfectly into our final provocative thought for you, the listener, to mull over.
Given everything we've discussed, the complex, sometimes contradictory roles of KOX1 and KOX2 in both causing inflammation and maintaining vital functions like cardiovascular and renal health, should our current clinical approach be even more cautious? Specifically, regarding the chronic use of all non-aspirin NSAIDs, even ones we often think of as relatively safe, like ibuprofen, especially in patients who might have multiple, maybe low-level coexisting conditions, perhaps mild hypertension, borderline kidney function, subclinical heart failure, things easily overlooked in a busy clinic. Are we sometimes too quick to accept the systemic risks of chronic NSAID use just for symptomatic relief, when maybe we should be pushing harder for non-pharmacological or alternative approaches?